also a retinoblastoma specialist. And together with my colleague, Dr. Kimani, we manage patients in Kenyatta with retinoblastoma. So I welcome you to today's CME, which is on decision making in the management of retinoblastoma, led by our very own Dr. Kimani. I know she's known to almost on everybody. She's taught most of us. She's a senior lecturer at the Department of Ophthalmology, University of Nairobi. And when we talk about retinoblastoma, we just think about Dr. Kimani. She's a pioneer in the management and the care of retinoblastoma patients. So we welcome her today to take us through this very important session. Thank you very much, Dr. Kimani, and welcome.
Thank you, Dr. Jambi. Thank you for that kind introduction. And I think we will just go right into the presentation. It's actually a very short presentation because, as you will realize, decision making in retinoblastoma is not it's not that hard. It just takes just some courage and having the interest of the patient at heart. So let me go right ahead and share my screen. So I hope you can see my screen.
Yes, we can.
All right, okay. So this evening we will just take a brief moment and just to talk about making decisions when dealing with patients with retinoblastoma or suspected to have a retinoblastoma. And I'll just have a few slides, and then at the end, I will share some of the cases where good decisions have been made, some where the decisions were a bit off, but we are all here to learn. So the outline, we are going to look at the diagnosis of retinoblastoma, the investigations that are relevant to retinoblastoma, and deciding on the treatment plan. And maybe at the end, I'll also briefly mention about follow-up. So a diagnosis of retinoblastoma, as we know, over 70% of patients, their initial symptom, actually 70 to 80%, the initial symptom will be leukocoria. That will be the initial complaint. And what that means is that most cases can be diagnosed clinically without any further tests. I always say retinoblastoma is one of those conditions where the ophthalmologist will take a look, and without any other test or investigation other than the ones relevant to general anesthesia, they will take the patient to theater and remove the eye just based on their clinical findings. Many times, in advanced centers, they will carry out quite a number of investigations prior to taking the patient to theater and carrying out whatever surgery or whatever intervention. But most of these investigations, they are not so much to make the diagnosis, but more to just convince the parent that this is the problem they are dealing with. And actually, B-scan is one of the main tools that can be used to augment the diagnosis. But even if the B-scan is not available, it's not to say that management of the patient should be delayed or that should not go on. And so it's very important for you as the ophthalmologist to have that confidence of being able to look into an eye, see this is retinoblastoma, this is retinoblastoma, and take the necessary action. And as I have said, the investigations mainly they are for purposes of treatment or to rule out extraocular spread of the disease. And so some of these investigations that you will make a decision to do will include a full hemogram, urea and electrolytes, especially if you're the one who will be taking the patient to theater, then you will need this. The anesthetist will even demand this of you. If you have ocular ultrasound, it is a good practice to make use of it because sometimes, and especially in our society that is becoming very litigious, then it is very important to, have some solid basis of why you did whatever you did. So if you have an ocular ultrasound, make use of it. I've even seen some centers where they just use the normal probe, even for abdominal ultrasound, and just to place it on the eye. And the most characteristic thing you will find is this calcified mass in the retina, in the vitreous or in the eye. And once you see that, you already know you are not in any doubt that you are dealing with retinoblastoma. In most advanced centers, MRI of the brain and orbit are standard as upfront investigations, but in our setup, we know how expensive and how inaccessible MRI is to many of our patients. And even in Kenyatta, usually we reserve MRI of the brain and orbit when we are suspecting that there might be some extraocular spread, and especially in patients who present with proptosis. You will see here, I have not put CT scan because we really try to discourage CT scan in children suspected of retinoblastoma because of the attendant risk of a heavy radiation and increased risk of a second non-ocular tumors. So that's why here you see I've not even put CT scan. But there are circumstances where it is the only imaging tool you have available. It's not to say that you cannot use it, and especially when you need to rule out any extraocular spread. So you can use CT scan, but if MRI is available, it is a better option. Abdominal ultrasound, CSF for cytology, bone marrow biopsy. These are mainly reserved for those patients that we are suspecting that they have extraocular disease. So when you see a child already presenting with proptosis, you can actually go ahead. If your center is able to do this test, go ahead and do this test so that even if you need to refer the patient, you already refer them with some results, and this will hasten the intervention so that they don't have to come and spend maybe 3, 4, 5 days waiting for investigations. And nevertheless, we never delay the management of the patient because of delayed investigations, or they don't have the money to do the investigations. We will still go ahead and intervene as appropriate, even as we are awaiting the patient to have the investigations done. So some of the important pointers when you're making the decision on the way forward in a patient you're suspecting to have retinoblastoma, you need to be able to decide, is it unilateral disease or is it bilateral disease? By and large, according to the best practice guidelines for retinoblastoma in Kenya, it is recommended that when it is bilateral disease, then that is a patient who should be referred to a tertiary treatment center. And a tertiary treatment center is where all the modalities of investigation or the modalities of treatment including globe salvage, are available. And when it is just a unilateral disease and you're confident enough that this is not an eye that can be salvaged, you can go ahead and enucleate, get the histology, and only refer the patient if they need further treatment based on the histology findings. And doing this saves time. We have seen patients who probably first presented to a health facility a year before they arrive at to Kenyatta, but when they are seen, they are told, oh, go to this hospital, they go to that hospital, they are told, go to this hospital, and they end up losing so much time that is so critical when it comes to retinoblastoma. And you find that a child who could have been very easily cured with just with enucleation ends up actually losing their life, or we end up spending so much money in treating disease that now has a very low chance of cure. So we always encourage as much as possible, learn to do a good enucleation. And even the enucleations, like for me, the enucleations I do at Kenyatta, I have learned it from YouTube. These days, YouTube is a wonderful, wonderful tool, and it will guide you as to how you can do a good enucleation so that you give that patient good cosmesis. If you don't do a good enucleation at the onset, you end up with contracted socket, you end up with a hypoplasia when you have not put an implant, and this becomes a lifelong burden for the patient when the cosmesis is not good. So as much as we are trying to save life, we must also remember the quality of that life that we are saving and always try to do a good enucleation. It's also important to take consideration of the age of the patient, because the younger the patient is, the higher the likelihood that they will have bilateral disease. And therefore, even as you're doing an EUA, you need to take extra care when it is a very young patient. And many times we have seen a tumor, a small tumor was missed, and it's only picked much later when it's bigger, and probably it could have been cured just by focal therapy if it had been picked early. So when it's a younger patient, especially those patients who are below 18 months, the likelihood that it is bilateral is much higher. Family history, it is so important to always remember to ask. Many times, if you don't ask, you will not get that information. In fact, there is a time we had this child referred from the coast, and it's only when we took history from the mom, we realized that one of the eyes, the vision was not optimal. Yes, she could still see. And when we examined that eye, we actually found a spontaneously regressed retinoblastoma. So sometimes when you ask family history, you'll be able to pick pointers that you could be dealing with a hereditary retinoblastoma, and you'll even be more careful to look for bilateral disease. Then also to decide, is this disease intraocular or is it extraocular? Because if it is extraocular, then upfront enucleation may not be in the best interest of the patient. It may also not be in the best interest of you as the ophthalmologist, because it's much more difficult to enucleate an eye that has orbital disease than an eye that just has intraocular disease. So once you examine and you decide whether it's intraocular or extraocular, it will help you decide whether this patient needs a neoadjuvant chemotherapy prior to enucleation or not. And when you find it is extraocular, it's very important to decide whether this is a curable disease or not. And when it is extraocular, it means you take care to check for distant metastasis, because once a patient has distant metastasis, it is very unlikely that we'll be able to cure that cancer, no matter what intervention. You'll throw everything at it, but you'll not be able to cure it. And so if you find already there is a distant metastasis, then it might be better just to think about palliation rather than referring the patient a long way, and they will not benefit from that referral. So if it is already metastatic, it may just be better to give, if, for example, there is a nearer center that can give chemotherapy, you could just refer them to the nearest center rather than referring them 300, 400, 500 kilometers away, and there'll be no benefit. And then also it's important to assess whether the patient will come for follow-up, especially when a patient has bilateral disease and they need globe salvage. This is one of the things that we struggle with, deciding whether they will come for follow-up, because we've seen cases where an eye could have been salvaged, but you start the salvage treatment and the patient gets lost to follow-up, and the next thing you see is they appear with proptosis and sometimes already with metastasis. So that is also an important point to take into consideration. So if you decide that you're going to enucleate the eye, then it's important to plan carefully. Yes, enucleation for retinoblastoma, we consider it an emergency, but that doesn't mean that you go in without a plan. Of course, consent is paramount. You don't want the patient to reach theater and that's when you're realizing that consent for enucleation was not obtained. It's important to have, this is something I really want to emphasize, that if you're going to do enucleation, make an effort to get orbital implants. And we recommend for any child who is a year or older, don't use anything less than a size 20 millimeters, because then it will end up being smaller than what should have been put, and the cosmesis may not be optimal. So try to get at least a small stock of size 18, 20, 21 implants, and they're not expensive if you can get them. The other thing we also encourage is, if you have stock artificial eyes, it's good to have one, and you can even put it on the table. And it makes a big difference when you remove the dressings from the eye and the mother actually sees their child doesn't have a hole in the face. They actually have something that looks like an eye. And we've not experienced any complications from using stock eyes on the table immediately after enucleation. Then if the one thing we advocate is the myoconjunctival technique. It gives you quite good cosmesis, but for this you need your double arm vicryl sutures, 6O double arm vicryl sutures, and these are not readily available in most hospitals unless you have already made an effort to order them and to have them beforehand. If you are asking for them when the patient is already on the table, you'll be told, oh, hizo hakunanga, those ones are not available. So then you are just left having to do, to make do without the best surgery that you could have done for the patient. It's also important to remember to dilate both eyes fully. Often, most of the patients will already come with an amaurotic pupil. They will in the eye with leukocoria. You may not need to dilate that one, but please remember to dilate the fellow eye and have indirect ophthalmoscope, an indenter or a squint hook or Q-tips to help you do a good dilated fundoscopy, because sometimes you may have a very small peripheral tumor, and if you do not do indentation, then you will miss it. So if you have not seen the ora serrata, you have not done a good EUA for the fellow eye. I can't emphasize good enucleation scissors enough. Many times you might find you end up with a short optic nerve, not because of your technique, but because of the kind of scissors that you have. In fact, I say in my set, everything else can miss, but not good enucleation scissors, because the length of optic nerve that you obtain at enucleation may change the whole outlook for the patient. Because as much as possible, you want a resection margin that is free of tumor. And the longer the optic nerve is, the higher the chance that the resection margin will be free of tumor. And so if you can get 15 millimeters, 20 millimeters, that would be super. You also need to have the specimen bottle ready. Otherwise, that eye could easily get lost in theater. Many times when you ask for the specimen bottle for the eye, they will bring you a tiny bottle that you have to squeeze in the eye. And you can imagine if you have to squeeze in the eye, what a nightmare it will also be for the pathology team when they're having to get out that eye. And always we recommend that the volume of formalin to the eye should be 1 to 10. And therefore, we really advise that you should have a container or a specimen bottle that can hold at least 100 mils so that you can put adequate formalin. Otherwise, when the eye is not well fixed, then the quality of histology may not be that good. So these are the things one needs to think about even as you're planning for the enucleation. Then while in theater, the first thing you want to do is EUA, and do EUA of both eyes. Don't just assume because it is a white reflex that it is obviously retinoblastoma. Sometimes when you do a careful EUA of that eye, you may find that actually it's not tumor that is in that eye. You may find it's just those the telangiectatic vessels with the retinal exudates that will be in keeping with Coats disease. You might actually find that actually it's a old retinal detachment, or it's a PHPV, because as we know, there are so many other things that could cause a white reflex in the eye of a child. So it is always important to take your time, examine even that eye that has a white reflex. Then also examine the other eye and do a careful examination. There is no need to rush. Take your time, do a good examination. Those who are high tech, you can take a fundus photo if you see a lesion with your camera. There are those who can do it. Also take a photo of the eye with leukocoria. It is always good to have these photos as evidence of what you found. During the fundoscopy, remember you need to draw the fundus findings. So you try and be keen. There is no need to rush, and view every bit of the fundus. And if you find something, make a sketch. I always say you don't need to be Picasso, but at least draw something that is in keeping with what is actually in the eye of the patient, so that if you need to refine, somebody looks at that fundus diagram, they'll not be thinking they are missing a tumor. It's only that it was put on the wrong part of the drawing. So, and as you do it, it gets better and better. If you find it is bilateral disease, even there on the table, you need to make a decision whether you're going to enucleate and refer, or you want to refer upfront. If an eye is group D, or if you look and you think that the eye has a chance for vision, and the other eye also has tumor, then it is good to give the patient the best chance. And maybe rather than enucleate, you could actually refer upfront. But this is a decision you will need to make on the table and decide, is this an eye that has chance for vision or not? And then also decide, are you best placed to give this patient the best cosmetic outcome if you enucleate? And these are decisions you may need to make on the table. And then whatever the decision you make, the most important thing is to keep the patient's best interest at heart. Even if the patient has bilateral disease and one eye is already advanced to level of group E, go ahead and enucleate, because that eye is a threat to the life of the patient. Sometimes you refer them and they'll take 2-3 months saying they're looking for money, or they'll start going to other places looking for second, third, fifth, 10th opinion, and they lose precious time and increase the risk of death for that patient. So this is an important decision that you will make even as you examine the patient on the table. So I'm just going to share a few cases that have been referred to us. So this is a patient who came from Bomet, and this was a very interesting case, because in Bomet, I don't know what he had presented with, but they had decided to go in and do vitrectomy. And when they went in to do vitrectomy of the right eye, it's when they realized that there was a mass in that eye. So the vitrectomy was abandoned and the patient was referred to us. And when we took the patient in now for enucleation, from the ultrasound, you could see that it was likely to be retinoblastoma. And when we went in to enucleate the right eye, we did an EUA of the left eye. And interestingly enough, there was a mass in that left eye. And so if an EUA could have been done before the patient before the patient was scheduled for vitrectomy, then once you find this tumor in this other eye, already, even if you're in doubt what you could be dealing with, it already tells you it can't be anything else other than retinoblastoma. But because what you realize is, by the time we were seeing this patient, he was 7 years. You don't expect bilateral disease in a 7-year-old. You expect bilateral disease in much younger patients. But as they say, diseases don't read books. And so actually we found he had a group A tumor in the periphery, and we were actually able to access it using a laser, and we did TTT for this left eye. Everything, there was no other tumor except that one small peripheral tumor. And within no time, we were able to control it. But now, because of the fact that the right eye had been opened, even though the histology report didn't indicate very high risk, like there was no scleral involvement, the resection margin of the optic nerve was not involved, but because the eye had been opened, now this had become orbital disease. And so this patient had to get a lot of chemotherapy plus radiotherapy. And being a bilateral case, already the radiotherapy is, you give it, you give it because it's going to save the life of the patient. but it's going to put him at risk of other tumors. So if an EUA had been done, this could have been avoided. But fortunately, the patient is doing well. He's in school, very good vision in the left eye, and we pray that he will live a normal life. This is a patient who was referred to us from Eldoret, had a nucleation of the left eye, and for 4 months they were treating this right eye that you can see has this tumor at the macula. So I think maybe they decided the patient was not responding well enough and was now referred to us. What we don't know is how this tumor was in the beginning. Was it this size? Was it still growing? And since we were also not very sure whether the chemo had been given the way it should have been given, we decided we will start this patient afresh. Like this was the first time the patient was receiving chemo, and so had to get another 6 cycles of chemo. And finally, we were able to control the tumor and do a laser. So this is a tumor that is right in the macula, and many of them, when you treat them appropriately with chemotherapy, they are able to shrink to the level where they at least leave part of the macula or even the fovea free. And so you are able to achieve good vision despite the fact that its location is very unfavorable for vision. So if you look at our guidelines, it clearly says that for bilateral disease, they should be managed at a tertiary center. And currently, the only tertiary center is Kenyatta. It's not that we want to hold these patients, but we just want the child to have the best chance to salvage an eye if it is salvageable. So this is a patient who could have been referred much earlier. This is one very sad case of a child who was referred to us from the coast, came to us August last year. The right eye had been enucleated, and while at the coast had already received 6 courses or more of chemotherapy. So by the time we were seeing this patient, you can see how that left eye looked like. You cannot even tell where the disc is. You can't tell where the macula is. The eye is just full of tumor. And in fact, we really debated, do we enucleate this eye? Do we try and give it a chance? The patient has traveled all the way from Mombasa, and we said, okay, let's give it a chance. So we tried systemic chemo, wasn't responding very well, although you can see in this picture after about 6 cycles, it has started to shrink a bit, but the disease is nowhere near controlled. We even referred the patient for intraarterial chemo. She received intraarterial chemo, and then the tumor just lost control and started growing. And eventually we had to enucleate this eye. So basically the patient now ended up being bilaterally enucleated. What we don't know is how this eye was initially. Maybe it was so bad still that it was beyond salvage, and maybe the patient should have had bilateral enucleation. But if you're in doubt, then this is a patient that should be referred early enough. So even when it is advanced disease, they may still have a small chance of salvaging the eye. Even if the vision doesn't end up being so good, there is a big difference between being able to perceive light and being totally blind. Then this is actually a case that came to us, and you can see we saw this child when he was 3 years old, and he had been referred to us because of a white reflex in the left eye. And fortunately, they came as soon as they were referred from a peripheral hospital. And on examination, he had tumors in both eyes, but they were both peripheral tumors. Both macula and disc were free, and vision was good. And so we decided to do salvage for both eyes. And this child actually did very well. We have been following him up, and for the last 1 year, the tumors have been well controlled, vision 6/6 in both eyes. And so the timely referral and the fact that the parents brought him immediately, we were able to salvage both eyes and give him good vision. This is also another case. This actually was referred from a clinic in Nairobi, somewhere in Kasarani. I was very impressed. In fact, I called that clinic just to tell them they're doing a good job. So was referred because of white reflex in the right eye. And when we examined, the patient has this huge tumor that is abutting the disc. It is right. It is on the nasal aspect. When we examined the other eye, we found there was also a small tumor. So this was a patient who, if it was only the right eye that was involved, then we would have discussed enucleation. But now when it is both eyes involved, then we made the decision to, Dr. Inoti, you'll mute, please. So we decided to give the patient benefit of doubt and do salvage for both eyes. And after 6 cycles of chemo and laser transpupillary thermotherapy, we were actually able to give her good vision in both eyes, because as you can see, the macula is free in the right eye. And so this child has excellent vision in both eyes. So the decisions that one makes when the first time you see the patient really has a bearing on what the result will be. So in conclusion, is just to remind us that retinoblastoma can be fatal, and time is of essence in saving the lives and eyes of patients with retinoblastoma. And it's important to make the right decision and act in a timely manner. It is in your power to make a difference. Retinoblastoma treatment can be stressful, but can also be very rewarding, and especially if you're willing to go the extra mile. This extra mile means that if you're referring a patient, please pick their number and maybe a week down the line, call them, find out whether they went to the hospital where you referred them. If they didn't go, find out why, and maybe there is something you can do. It may just that they don't have fare, and sometimes just giving them that 500 shillings will save the life of that child, or will save the eye of that child. So let's go that extra mile. Thank you. That's the end of my presentation. I just want to take this opportunity to thank all of you out there who are really fighting for these children. Thank you for your referrals. And we try to make an effort to let you know that the patient came. And if we don't let you know, please don't hesitate to just give us a call and just check on whether the patient arrived, and we'll be happy to update you. Asanteni sana.
Thank you. On the retinoblastoma. So before we do the Novartis to make their presentation. Please put questions. We will look at them after this Novartis.
I'll be happy to answer any questions. Please feel free to give comments, suggestions. I'm sure this is one area where we can always do better.
Thank you. Please put your questions, comments, clarifications. Do you have a representative from Novartis?
Dr. Jambi, your audio is, don't know why it's having issues. We can barely hear you.
Okay, can you hear me now?
Yes, that's better.
Okay, thank you, Dr. Kimani. I was saying that we can post the questions and the Q&A as we wait for Novartis to give us their presentation in the meantime. Do we have someone from Novartis?
Yes, Dr. Njambi. I hope you can hear me.
Yes, you're welcome.
Thank you very much. This is Gilbert. Kindly confirm when you can see my screen.
You can see.
Thank you very much. And sorry for not putting my camera on. So mine is a very brief presentation. We are here with my colleague, Chloe Jambo. So, and Dr. Kimani, thank you very much for the great presentation you've done. So good evening, everyone. So today we are just going to share something on our new kid on the block when it comes to our retina solutions by the name PageNax. So the molecule is brolucizumab, and we launched sometimes last year. So today we are just going to look at how we've reimagined wet AMD and also DME treatment. And we'll focus on the drying and durability with PageNax. So before we proceed, I know all of us knows the role fluid plays a significant role in wet AMD and also DME management. And CSFT and fluid levels are important in pathogenesis of wet AMD and DME. Also, guidelines recommend that treatment decisions are to be based on the presence of the fluid on the OCT report. And persistent fluid may lead to lower vision gains in both wet AMD and DME. CSFT fluctuations are associated with the poor vision gains in wet AMD and DME. That's why you need an agent that dries faster and better, and this will be associated with good visual gains. So you may ask yourself, why do we have this PageNax? I know we've got so many injections. We have the bevacizumab, we have ranibizumab, aflibercept. So you may ask yourself, why another injection at this time? So what happens is we still have a significant unmet need for many patients with wet AMD and also DME, as documented in so many studies. And these are three main concerns in terms of adherence: the high injection burden, and also the suboptimal dosing. So in terms of the adherence, the study showed that 70% of the patients are normally undertreated in the first year of treatment, and 60% of the patients don't adhere to the treatment. In terms of the injections burden, 50% of the patients received injections more often than every 8 weeks during the first year of follow-up in a real-world study. And for the suboptimal dosing, 80% of the eyes received 3 or less intravitreal injections for 1 year. An agent that provides maximal sustained VA gains with longer treatment-free intervals may be needed, and that is PageNax. So currently PageNax is approved for 2 indications, basically the DME and wet AMD. So we'll just look at the summary on what you get when you have a patient with DME. So what do you get from PageNax? So currently we have some few studies which were used to approve PageNax. In terms of the DME, these are the two studies, which is Kestrel and Kite study. So as you can see, so this Kestrel and Kite study were comparing PageNax with the aflibercept. So as you can see, the two molecules in terms of comparison, in terms of the BCVA letter gains, for brolucizumab, you see there was a comparable vision gains when you compare PageNax and also aflibercept. But of importance is for PageNax, there was a better drying. So you can see they were compared in terms of BCVA and also the OCT outcomes. So in terms of the percentage of patients with IRF and SRF, there were few patients for PageNax compared to those patients who are on aflibercept. So this is the conclusion of this study. It showed that there was a greater percentage of PageNax treated patients achieved dryness and sustained dryness when you compare with those who were treated with aflibercept. When you compare the time to first absence of IRF and SRF, it was shorter in the PageNax arm compared to aflibercept arm. Something else to note is by the end of 52 weeks, 50% of PageNax treated patients were able to achieve sustained dryness and also sustained CSFT of less than 280 micrograms. So you can see PageNax is best in class when you're looking at the drying effect. I will not go to this very busy slide, but the two studies which were done to compare the safety and efficacy of PageNax to aflibercept. So we had Hawk and Aria and also the Kite and Kestrel, the ones I've just discussed. So overall, in terms of all the other side effects, PageNax had a well-tolerated safety profile across the two indications in the long term, and there was no new safety signal seen. So in terms of managing wet AMD, what does PageNax offer? So the key trial was Hawk and Aria, and PageNax has proven its efficacy in patients with wet AMD in this study. So PageNax also showed a comparable visual gains with more fluid resolutions at 96 weeks. So as you can see, in terms of BCVA, they are comparable with the aflibercept. But in terms of percentage of patients with complete absence of IRF and SRF, you can see there are more patients who are on PageNax, and also percentage of patients who sustained presence of IRF and or SRF, they're also less for PageNax. So this is in summary. What do you get when you give your patients PageNax? So what you get is a sustained vision gain with a smaller number of injections is seen with PageNax compared to aflibercept. So as you'll see later, for PageNax, after the initial dosing for the 3 months, you can just keep the dosing you give patients once in 3 months. There was also a treatment-free interval, which can be extended up to 12 weeks post-loading, as I have said, and this was shown by the Kite study at 100 weeks. There is also a higher CSFT reduction with less fluctuations seen with PageNax compared to aflibercept. And PageNax has shown faster and more drying in terms of reduction in IRF and SRF versus aflibercept. This is not just theory. Initially, when we launched, it was appearing like a theory, but we've heard even from the people who've given their patients. I think so far we've had quite a number of patients who've benefited from PageNax in Kenya. So something else to note is 65% more patients gained greater or equals to 15 letters, even in wet AMD patients with early persistent fluid versus aflibercept. PageNax also showed more reduction in subretinal pigment epithelium and PED thickness compared to aflibercept. Thus, PageNax is a durable drying agent for management of wet AMD and DME with a well-tolerated safety profile. So what differentiates Paginax from other anti-VEGFs in the market? So it is basically in terms of fluid resolution, and this leads to faster drying and longer intervals. So if you've not used Paginax for your patients and you're wondering what Paginax can give to your patients, can assure you that Paginax dries better, faster, and longer. So you can give your patients what they want. That's the vision, with less frequent injections compared to other anti-VEGFs. So the big questions you're asking is, why should your patients wait when we have Paginax? Thank you very much.
Thank you, Gilbert, for that presentation on Paginax. I hope it's also more affordable to the patient. On the chat, I see a lot of applauding comments for Dr. Kimani. Thank you very much for the presentation, for the reminder, for the update, for the new knowledge. Awesome presentation. Thank you. I don't know whether you have any other additional comment or anybody who would want to ask Dr. Kimani a question directly. I'll give you a minute. As we wait, maybe I'm sure Dr. Kimani mentioned it, but it's when you have late presentation in bilateral disease, because that's why you have to make very tough decisions. And at times we've had to keep the 2 eyes in the beginning for salvage as we wait for response. And at times what we thought initially was what looked like a better eye ended up being not being the better eye in the end. But as Kimani said, the time is what makes the difference in everything. If we can be able to get the patient early, you get much better outcomes. There's one comment, one question. Do you do MRI brain and orbit for cases or only for meds? Maybe Dr. you can just clarify then. I know you mentioned it.
Thank you for that question. And one of the things I said actually in
Marcy, how are you?
in advanced centers, they
I'm good.
Was 7,000.
Huyo ni nani? Who is that?
7,000.
Gilbert, you need to mute.
Nakwambia.
Gilbert, please mute.
The first plant had 7 heads of grain. The next plant had 7 thin heads of grain.
You know that funny. So nice to see you. Okay, so when it comes to MRI imaging, in advanced centers, they do it for every patient with retinoblastoma. But as you realize in our setup, MRI is not easily available, and for many patients, it's not even affordable. And so for those who can, we will do it upfront. But for most of our patients, we will only do MRI when we are suspecting extraocular spread. So it is, we have not made it mandatory that every patient with retinoblastoma must have an MRI. But if the patient can afford, you're in a center where it's available, or the patient has insurance that can cover, then it is a good thing to do. However, don't delay the management of the patient waiting for that MRI. I hope I have answered the question sufficiently.
Yes, thank you for that. There is another question. Why is retinoblastoma rare in adults? Maybe you can explain, Dr.
The reason why retinoblastoma is rare in adults, it's because retinoblastoma arises from primitive embryonal cells in the retina. And it is usually young children who will have an abundance of embryonal cells. And that's why you find embryonal tumors mainly affect children. And as a child grows, the embryonal tissue becomes less and less, and therefore the risk for retinoblastoma becomes less and less. And that's why you find even in the follow-up, when a child is young, we follow them up very frequently, like every 3 months, even when they have unilateral disease. But as they grow older, we increase the intervals between follow-up. And so you'll find by the time a child is 5 years, the chance that they can get bilateral disease is much, much lower. And that's why now we will just follow them once a year. But diseases don't read books. We have seen adults, we have actually seen a 30-year-old teacher with retinoblastoma. And we have seen quite a number of older children with retinoblastoma.
Thank you. Dr. Mary has asked a very interesting question. For unilateral group B and C, do you consider them for globe salvage?
Yes, we do. And even group D, there are patients who we have done a salvage for unilateral group D. When a patient is unilateral and there is still good chance for vision in that eye, we will do whatever is necessary to salvage that eye. We also have cases where parents absolutely refuse enucleation of unilateral retinoblastoma with a very poor prognosis for vision, and we will counsel them, tell them what it will take if they decide to go the globe salvage route. And we have a few patients who we have actually salvaged unilateral retinoblastoma. So it can be done, but always to remember, life of the patient is paramount, because you don't want to end up losing the life of a patient because you are attempting to salvage a unilateral retinoblastoma that had no chance of gaining vision.
Another question from Dr. Mienzi that you mentioned there are exemptions for the use of CT scan. Do you mind stating these exemptions?
The exemptions or?
CT scan or use of CT scan.
So what I said is that for children with retinoblastoma, and especially those with germline mutation, they have an increased risk of second non-ocular tumors, and especially osteosarcoma, soft tissue sarcomas. It has been found that when they are exposed to radiation, this risk increases. And therefore, we know, like for CT scan, it exposes the child to very high levels of radiation. And you'll also find even like pediatricians, they want you to avoid CT scan in children who are below 2 years because of this radiation. But sometimes it may be the only diagnostic tool you have. Like for example, when a patient has presented with orbital disease, and you need to decide, has it metastasized intracranially or not, so that you make a decision. Are you going to are you going to treat this patient to cure, or are you just going to give palliative treatment? Then CT scan may be the only thing that you have in your hands, and you could still go ahead and use it.
Thank you. Thank you, Dr. Kimani. I don't see any other question. Oh, there's one more. How do you go about bilateral group E, considering social factors associated with enucleation?
That is always the tough one. But when it is bilateral group E, your options, you don't really have options other than enucleation. You don't really have options. I know in the West, they have even gone to try and do intraarterial chemo, but yes, you may control that tumor, but you'll not have vision in that eye. And it would mean that this is a child who is getting so much chemotherapy for so many years, and for what benefit? Yeah, but convincing a parent to consent for bilateral enucleation, that is usually not easy. But there is still quite a number of patients where we end up doing bilateral enucleation upfront.
Yes, and thank you for that. There are cases actually where child got metastases while trying to, in the West, while trying to salvage group EI. So it's always very dangerous attempt to salvage the eyes. I think one or two more. Thank you. Do you manage Bufamo the same way as an orbital disease? That is from Dr. Zara.
Okay, so Buphthalmos is not the same as orbital disease. Buphthalmos just makes an eye group E and therefore should be enucleated. And but most people, because of the risk, when you have buphthalmos, the sclera is very thin, and there is the risk that you could perforate the globe during enucleation. So many people usually will give upfront chemotherapy to try and shrink the tumor and minimize the risk of perforating the globe, but it doesn't make it orbital disease. And this is one time when MRI would really, really be helpful before you start chemo, so that, because again, you do not want to subject a child to too much chemo when they don't need it. So an MRI would really help you decide, is there already optic nerve invasion? Is there orbital invasion? And this will help you to decide whether after you give the chemo and enucleate the eye, whether further treatment will be needed.
Yeah, and thank you for that question and the comment. Actually, last week we had a child with very severe buphthalmos, and since the pressures were normal, we thought we could do upfront enucleation, and it was a very tough and tense eye. And after the enucleation, what we noticed, there was some so it's always
Your audio, Dr. Jambi, is doing some stunts.
I think it's my internet.
Okay,
Is that better?
a bit better, yeah.
Okay. I was saying there's a case we did last Monday with buphthalmos. It was very quick. We did upfront without chemotherapy. Sometimes we give, when the pressure is high, we normally give a chemotherapy before. This time the pressures were okay, and we thought we could do upfront enucleation, and it was actually a struggle to remove that eye. It was tight, it was tense, it was feeling the orbit. So it's always you need to weigh the case, and sometimes it may just be helpful. But the staging, whether you give them or not, does not change the staging. The other comment is what about unilateral CNS involvement? I think this was still about looks like a continuation of a question that was there before.
Okay. Maybe Dr. Maulid, maybe you can unmute and maybe explain your question. Oh, because it's asking, what about unilateral CNS involvement?
It's the same one who had asked about the bilateral enucleation.
Okay.
Yeah, I guess maybe bilateral.
Good evening. Good evening.
Good evening, Dr. Maulid.
Sorry, I missed that presentation, and I have a case of unilateral CNS involvement. So I wanted to ask, how do you go about? And the other, it's a unilateral, the other eye is normal.
Once you have CNS involvement, then you can only do palliation. No matter what you do, you'll not be able to save the life of that patient. And so you just do what it takes to make the child comfortable.
Thank you, Dr. Bishani.
Please don't send them to Kenyatta if you have a place where they can get chemo nearer home.
Dr. Gishangi has commented that you can find the guidelines at the MOH website about the management of retinoblastoma. Dr. Kipsang is asking whether there are any donors for the less fortunate children. Dr. Kimani.
Unfortunately, we don't have any donors, but I know like at Kenyatta, we have Hope for Cancer Kids that helps to pay for, okay, it used to be an HIF and now I guess SHA. But beyond that, we don't really have any donors that we can talk about. So please, if you can connect us with any, we would really appreciate. We would really appreciate.
Thank you. I don't see any question or comment. Thank you very much. Thank you everyone for the engagement. Hope that all of you will continue being champions for children with retinoblastoma. So I'll put you back now to conclude the session.
Thank you very much, everyone. I really appreciate your participation, and please keep up the good work. Keep fighting for your own corner, for whichever corner you're working in. Please keep fighting for the patients. Thank you.
Okay, thank you everyone for attending today's CME. Just a reminder, let's remember to pay our subscription, because from this month only the paid up members will get CPD points. And have a good night, and you're free to leave. Thank you.